Good evening. It's so exciting to see people back out and about and having a full house this evening for Dr. Johnson. I am Penny Stoss, and I get the privilege of introducing Dr. Johnson this evening. Dr. Johnson and I started here at the Hutchinson Regional Healthcare System at the same time, so that even makes it even more exciting to get to introduce her. But I want to tell you a little bit about her before she comes up here and visits with you about primary care. So Dr. Johnson is a Hutchinson native who graduated from Buehler and then attended K-State, her undergraduate degree, before moving on to KU Med in Kansas City for her medical training. While in training, Dr. Johnson took a special interest in minor surgery and gynecological care, which led her to her current clinical practice services. Additionally, she has obtained unique training in the practice of bioidentical hormone replacement. And additionally, replacement, and has provided these services to her patients since 2012. Dr. Johnson values the development of personal relationships with her patients so that she can truly realize each person's unique goals and their needs. She strives to fully listen, to understand, and she spends extra time explaining diagnoses, evaluations, and treatment options to her individuals and to her families. Dr. Johnson lives here in Hutchinson with her husband Scott, as well as their dogs, cats, and chickens. They have 3 grown children. She has twin daughters, Brianna, Malin, and a son, Austin. And in their free time, they enjoy traveling to new places, with her favorite location being Iceland. Yeah. So she is board certified by Family Medicine. Her professional organizations are American Medical Association, American Academy of Family Physicians, American Academy of Aesthetic Medicine, and a Medical Society for Sedgwick County. We know that going to see your doctor can be stressful, and Hutchinson Regional's new primary care providers are here to help. And at Hutchinson Primary Care Associates, we have thoughtfully set the stage to provide our patients with a friendly, hometown, safe place to visit your doctor. Your medical providers, nurses, and support staff at Hutchinson Primary Care Associates personally understand the concerns that come with seeing your doctor. And that's why you will be treated like friends and family every time you visit. The same staff will greet you with a smile and a hello as you check in, and the same nursing staff will be there to start your visit, and your medical provider will be there to see you. Dr. Johnson is leading this charge, and we are excited that you're going to get to hear from her this evening. Dr. Rogena Johnson.
Hello. It is great to see so many people. We haven't been able to do this in 2.5 years, I'm told, so it's really nice to see so many people here this evening. So Penny already kind of took this over for me, so I could just skip through this real quick, but I just wanted to kind of tell you a little bit about me. I am from Hutchinson. I went to Buehler. And then I decided I wanted to become a wildcat, so I went to K-State. And then that wasn't enough. I needed a foot on both sides of the street, so I became what we call a J-Doc at KU Med in Kansas City. And then I decided to stay on there at KU Med and do my family medicine residency. At that point in my life, I decided I wanted to get out of Kansas a little bit and maybe see the ocean, so I moved to Florida. And I loved it. I lived on the east coast of Florida, about halfway between Miami and Orlando. And once I got there, I realized that I hadn't really left home behind because I lived right by Hutchinson Island. So as crazy as I thought that was, all the people that I met there, when I told them I was from Hutchinson, Kansas, they thought that was just so crazy. So I had a little bit of home right there in Florida. But as the saying goes, you can take the girl out of Kansas, but you can't take Kansas out of the girl. So here I've been back for about 10 years now. And besides being a doctor, the things that mean the most to me are my family. So this is a picture of my family and my chickens. So chickens are my pastime. I'm a chicken tender. Anyway, so that's enough about me. We'll get into kind of the nuts and bolts of this presentation. So, of course, I think it's important to have a primary care doctor because I'm a primary care doctor. But why should you care about having a primary care doctor? So, there are some things that I think are really central to that relationship. And the first is that you can have somebody who's truly a partner in your care, who knows you personally and what your goals are, because everybody does have different goals for their health, and knows your history well. Also, someone who can be your healthcare captain or a quarterback or an umpire or whatever you want to call it, but someone who coordinates your care all in one location. And that's something I have really appreciated about being part of Hutch Regional Health System, because I have a lot of different things at my fingertips here in this system. Also, illness prevention. So we provide regular screenings to catch disease early, because that's important, and also tips on healthy living. If we're doing a good job, hopefully you go to the ER less, or if you have something urgent, you can come to our office instead of going to the the ER. And then just that comfort and familiarity of having someone who knows you, that you trust, and you feel close to. So how do you find a good primary care doctor? Again, the first step here is where we left off just a second ago, and that's someone that you feel comfortable with. Someone who you feel you can be honest with, that you can ask questions, and that they understand what your needs are and how to explain things to you so that you do understand. Also, training, so board certification can be important. Office hours, so what are the office hours? Does it fit your schedule? Also, talking to someone who's been to that practice before. That's a good way to find out if that's a practice for you. What do other people think about that doctor or that practice? And then what happens if your provider is out? How do you get a hold of your provider, your doctor? How do you what happens on evenings and weekends and holidays? So those sorts of things are important to think about when you're choosing a primary care provider. So a little bit about Hutchinson Primary Care Associates. This was my initial staff in March, just 6 people. And we opened on the 3rd floor of the hospital, unit 3100, and we're still there right now. They've remodeled. It's beautiful. If you have a chance, you can come by and take a look. We are open Monday through Thursday from 8 to 5 and Friday from 8 to noon. And we do have the 24/7, 365 call, so you can get a hold of us after hours. We see patients of all ages. Anyone is welcome. And one thing that's really important to us is that this is our hometown, and we want to treat our patients like family. This is our staff as of yesterday. So we've almost doubled in size, and we're continuing to grow. The picture on your right is one of our exam rooms. This is my sunflower room. So I have a sunflower room, a beach room, and a mountain room. I kind of themed them to kind of remind me of those places. And I'm very excited to announce that I have 3 new practitioners who are actually 2 who have started and 2 who are starting next month. Corwin Nozari and Jessica Knight have already started. They are completing their training this week, and then they're going to start seeing patients next week. And then Alex Jones actually will start next month. And then I have a 4th provider who will join our team next month as well. So when I saw this picture, I thought of the heart. Obviously, what's at the heart of who we are, what's at the heart of the type of practice that we are building at Hutch Regional. How are we really going to make a difference? And when I thought about this, it reminded me of why I wanted to come to Hutchinson Regional. So Hutchinson Regional has the core values of eye care. They're actually right up here on the wall. And so these are things that really resonate with me, that I find important to myself and in my practice. So I care stands for integrity, compassion, accountability, respect, and excellence. And those are things that we are keeping at the forefront of ourselves as we build our practice, and the things that we're going to hold true to. Again, sticking to our central theme of hometown health care. I live here, my family lives here, I'm going to be here for a very long time, and so I want to treat patients how I would like my family to be treated. And then bringing the primary care, PCP, or primary care provider, back into the picture for hospitalizations, and this is an evolving concept. So at Hutch Regional and at many hospitals, when you are in the hospital, a hospitalist takes care of you in the hospital. And then your primary care doctor takes care of you in the office. And so if it works well, there's a good interconnectedness of that. And if it doesn't, it can feel disconnected. And so as someone who's practiced in Hutchinson for several years now, almost 10, I would like to get back to feeling more connected to my patients in the hospital. And so that doesn't necessarily mean that I will assume all responsibility for the patient's care that entire time, but we're working on piloting a program where we've already actually started, where my nurse goes and does a bedside visit, because we're right there in the hospital on Unit 3100, so it's not too far for us to walk. So we can go see our patient, the nurse will make a visit with the patient and see how things are going, find out some concerns, and sometimes there aren't any that need my attention, and sometimes there might be. And in that case, then I can talk to my partner, that's the hospitalist, and try to kind of negotiate what needs to happen for that patient. And also sometimes it's just about supplying information. So sometimes when someone's not feeling well, they don't remember their entire medical history or all the medication changes or what tests they had done last month or last year. And so that's my job. I'll provide that information to the hospitalist. The other thing that I kind of already touched on, but that I enjoy about working within the hospital system is that it's a system. So we have our outpatient practitioners, we have a hospital, we have the emergency department, we have home health, we have hospice, we have durable medical equipment, we have a lab, we have x-ray, MRI, all of those things in one system now. And that's unique for me to work inside of a system like that. So speaking about my partners, these two guys are a couple of my personal heroes. They are the pulmonologist at Hutch Regional who kind of have led this hospital along with another pulmonologist in town, Dr. Ashraf, in leading us through COVID. And so these are very smart guys. Actually, I have several family members and friends that see them. Dr. Al-Halawani actually trained at Yale, which is incredible for us here in Hutchinson. And Dr. Musa trained at the University of Columbia, which is also a very prestigious program for critical care. So they're also right down the hall for me. So when I have a patient who needs a pulmonology service, I can walk down the hall and talk to them, so I like that. And I'm not going to do this much justice because I don't fully understand their Zephyr valve, but this was something that was super exciting. Dr. Al-Halawani actually was recently named a fellow for the American College of Chest Physicians, and this is a really prestigious worldwide organization that we're really super proud of him for. But most of this slide is talking about the Zephyr valve, and so this is for people who have COPD. Sometimes the COPD gets bad enough that drastic measures need to be taken, and sometimes that involves removing a lobe of the lung, which is, as you can imagine, not an easy procedure. And so this valve is something that Dr. Al-Halawani started here, and then Dr. Musa soon followed. And in doing this, they don't have to do that type of a large procedure. They can just insert this tiny little valve that's the size of a pencil eraser down through, not the outside, but down through, going through the throat into the lungs through a bronchoscopy to help close off a part of the lung so that what's left is the good tissue. And we block off the bad tissue that's not helping someone breathe. And so this can dramatically help people with COPD. So I'm just super excited to have that service offered from one of my team members. Two more of my heroes is our cancer team. I never want to tell a patient they have cancer. That's one of the worst conversations to have. But I now work with two wonderful ladies. One, Dr. Amira on your left, is our hematologist oncologist, and then Dr. Shirley Butler on your right is our radiation oncologist. So now if someone does have cancer, I can refer to one of my partners and have, if they need chemotherapy or radiation or both, have that done and have that person, those people be on my same team. And so that really has helped me in transforming my ability to care for patients with cancer. Just a little bit more about them and pictures. We really have a state-of-the-art machine for radiation therapy. Dr. Amira was actually recently featured in the Wichita Business Journal as one of the top oncologists in our region. She is fantastic, and Dr. Butler offers cutting-edge radiation therapy right here in town. So those are the people who can treat you if you get cancer, but I'd like for people not to get cancer, obviously. Prevention is better than cure, and that's where we kind of come back around to primary care and what we can do in primary care to help people stay on top of their health. This one might be a little fuzzy, but it's Hippocrates, and the greatest medicine of all is teaching people how not to need it. And that really is central to primary care. So of course we can manage medications and help people get tests they need, but a big feature of what we do in primary care is just figuring out someone's lifestyle and little switches or changes we might be able to do to be healthier. So I'd like to talk a little bit about kind of the top 4 cancers that on a day-to-day basis I talk about with patients and we screen for. Breast cancer, cervical cancer, colon cancer, and lung cancer. So breast cancer is diagnosed mainly with mammogram, and we recommend those about every 1 to 2 years. It depends on the patient and their individual circumstances. Cervical cancer, we screen with a pap smear every 3 to 5 years, depending on the age of the person and again their risks. Colon cancer, we screen for every 3 to 10 years, depending on risk. And then lung cancer is relatively new in the last 5-ish years that we screen for lung cancer with more than what we used to. We used to just use chest x-rays, and now we actually use CT scans every year if people fit the criteria. So I'm going to go through each one of these. I can't say this one enough. 1 in 3 cancer deaths could be prevented with early detection. That's something that really, I like to let sink in, because there's a lot of reasons why people might choose to or not to get screened, but screening is really the key to preventing cancer death. So I'm going to start with breast cancer. There's a lot of stuff going on this slide, I understand. So the things that are kind of most important is that this year, about over 200,000 people will be diagnosed with women will be diagnosed with breast cancer. And the biggest statistic, I talk about this, I think almost daily, 1 in 8 women will get breast cancer at some point in their life. And 85% of diagnoses occur in people who have never had breast cancer in their family. And that's important because I have a lot of patients, regardless of what cancer we're talking about, who say, well, no one in my family has ever had that, so I don't think I need to be screened for that. And that is absolutely not the case. We don't want you to be the first one in your family, but you might actually be the first one in your family to develop a form of cancer. And so we want to screen early so that we can stay on top of that and treat that very early. The good news is that the death rate from breast cancer has been declining very rapidly since 1989, and that's because of early detection, which we thank mammograms for. And another kind of meaningful number I like to think about is the one on the bottom right, that breast cancer education and screenings can save up to 37 lives every day in the United States. So the more we talk about it, the more we talk to our family about it and our friends, and we're advocates for people to get screened, the more people that we might help. So it's not as easy as just saying someone needs a mammogram. Sometimes people are resistant to getting screened for any type of cancer. And so there's some myths that go along with breast cancer screening. So one of them is that breast cancer only affects middle-aged women, and that is not true. Actually, the incidence of breast cancer increases as we get older. And so it's something that we continue screening for many years. It depends on your individual health. But as long as you have a good life expectancy of 5 years or more, we continue screening people for breast cancer. Another myth is that if a lump isn't painful, it can't be cancer. That's absolutely not true. It's usually true, but it's not always true. The family history, we talked about that family history doesn't necessarily mean if your family has never had breast cancer that you cannot. Another one I hear a lot is that radiation from mammograms cause cancer, and that's absolutely not true. The dose of radiation from a mammogram is minuscule, comparable to a plain X-ray. And the last on the left-hand, or your left-hand side there, is that breast cancer can't be cured. It's a death sentence. That is absolutely not true. Many women survive breast cancer. Mammogram myths kind of center around similar things, that mammograms might cause cancer. That's not true, that they're not accurate. Mammograms are the most accurate tool we have right now. And another one is that mammograms are painful. And mammograms have changed dramatically over the last several years. And, what I would call an older school mammogram was a flat plate. It kind of did cause some pain. And if you've ever went through one of those, it might not have been the favorite day of your life. But nowadays, mammograms are are three-dimensional. And so there's much less compression of the tissue that's necessary to see. And so that technology has really transformed mammograms and made them relatively painless. Switching gears, cervical cancer. We do, the recommendations for cervical cancer have changed also, as many things in healthcare, but we used to start cervical cancer screening or pap smears at age 18, and now we start at age 21, and we continue until age 65, unless there are some risk factors that someone has that would necessitate us continuing to do pap smears after age 65. So any type of cervical cancer or dysplasia or an abnormal pap smear might necessitate continuing to do pap smears after age 65. So this technology has also changed. Now there is a pap smear, which essentially is where they look at the cells under a microscope, or they use some computer technology to help them with that now, to see what the cells look like. But now also an HPV, or human papillomavirus DNA test, is ran, because that's the most common cause of cervical cancer. And so with the advent of the HPV, what we call co-testing, or testing both at the same time, we've been able to space pap smears out to every 5 years, which is much easier for most people to comply with. Again, with cervical cancer screening, there's a lot of missed opportunities. And so I know this is a few years ago, 2012, but in that year, 8 million women, and these are women between the ages of 21 and 65, so a decent percentage of our population had not been screened in the last 5 years. And you might think, well, maybe those are the women who didn't have a doctor or who didn't have health insurance. That's not the case. 7 out of 10 of those women had both a doctor and health insurance. And now we also have programs in the state of Kansas. There's a program called Early Detection Works, which is by the Susan B. Komen Foundation, which helps women get pap smears and mammograms at no charge. I did provide some brochures on that if you would like, if you have anyone that you know that, or you might be interested. It's a great program. And again, I mentioned HPV. So HPV is what predominantly leads to cervical cancer. So now we also have a vaccine that helps prevent HPV, and that has greatly reduced the incidence of cervical cancer as well. Switching gears again, now we'll talk about colon cancer. Similar to the last two things, some of these recommendations or testing have changed also in the last several years. You might recall that most of the time we've talked about starting colon cancer screening at age 50. That has now been changed to be age 45 as more and more information has come out about colon cancer affecting younger people. So now we recommend between the ages of 45 and 75, people get screened with one of several tests, which we'll go through here in a second. Between the ages of 76 and 85, it's a discussion with the doctor and a decision as to whether, your personal history and your current health as to whether the screenings are continued. After age 85, we don't always continue to screen. So there's a lot of different potentials for screening for colonoscopy, or screening for colon cancer. The best, what we call the gold standard, the best test is the colonoscopy. And that's because it's both a diagnostic test and it can be a treatment at the same time. So with the colonoscopy, they're going to use a camera to be able to see the entire colon, as opposed to the flexible sigmoidoscopy where they only see a portion of the colon. During that test, they can also take biopsies of anything that looks suspicious. And if there are polyps in the colon, so little growths on the inside of the colon, those can be removed. So polyps might start out as inconsequential and benign, but eventually they could turn into cancer. And so during a colonoscopy, those have a chance to be removed so they couldn't hurt you later down the road. There's some stool tests that we don't really use very frequently anymore for this type of screening, but they've been around, so they're worth mentioning. And those are basically the tests that check for blood in the stool. But as you might imagine, those aren't the best tests because things that aren't cancer might bleed, like a hemorrhoid, and cancer doesn't always bleed. So you can have both false positives and false negatives. We talked about the flexible sigmoidoscopy. I'm going to come back to the DNA test here. And then the CT colonography is Again, something that's kind of a last resort in my mind if someone doesn't want to do any other test. But basically, it's a CT scan using some contrast to be able to see the lining of the colon. But some cancers, unfortunately, are flat in nature, and so those would, of course, be missed on that type of a test. And so the last test I want to talk about is the Stool Dna Test, and this one goes by the name Cologuard locally, or in the United States, I guess. And this is a pretty common test for people who aren't ready yet to do a colonoscopy. It's about 96% accurate in detecting colon cancer. The main drawback is there are some false positives, so sometimes it overcalls the result, in which case about doing a colonoscopy. But I do think it's a good option for people who aren't ready to do a colonoscopy. So this is on colon cancer. I wanted to talk a little bit about some of the risk factors for colon cancer, the first being age over 50, use of alcohol and tobacco, lack of physical exercise, that actually is a risk factor for breast cancer as well, a low fiber diet, which tends to happen commonly in our culture, personal history of inflammatory intestinal conditions, and in this one there is a family history that is linked, but again, that doesn't necessarily mean that it's not possible to be the first one to get colon cancer. So the colonoscopy, as I mentioned, is my favorite test to order for colon cancer because it's the best test, but I have plenty of conversations on a regular basis about trying to get people to do it, and they don't want to do it. And there's a lot of myths about colonoscopies. And one of the first is that the prep is the worst. I hear that all the time. The prep is the worst. It's gross. I don't want to drink all that. But now the prep has actually changed. So if you hadn't had a colonoscopy lately, it actually has gotten a lot better. It can involve Gatorade and some Miralax. It's not the way it used to be for most of the time. I can't promise you every colonoscopy that's done doesn't involve the Go Lightly old type of prep, but most of the time they use the newer prep. Prep doesn't take forever. You don't have to take a whole week off to do it. You start at noon the day before. It's going to hurt. Well, in fact, you should be asleep and not remember any of it, so hopefully it wouldn't be painful. Again, I don't need to have a colonoscopy until my cancer symptoms have started. That's something that we don't want. We don't want to wait until you have symptoms of cancer to screen for cancer. We'd like to screen and detect it before you have any idea there's any kind of concern, so that you can actually be treated with much less invasive treatment than if you had waited. Getting a colonoscopy is humiliating or scary or embarrassing. Well, there are professional teams who do this. That's their job the whole day. That's what they do, is colonoscopies, and it's an important job, and so your privacy is very much respected. And then the last is about being able to afford preventative care, and so this is something that with the Affordable Care Act, actually preventative screening should be covered at no out-of-pocket cost. So a preventative or a screening colonoscopy or a screening mammogram or pap smear or lung cancer screening, those are covered at no out-of-pocket cost. Okay, the last type of cancer screening we're going to talk about this evening is lung cancer. And this one's relatively new, and there are some specific criteria that help determine whether or not you're eligible. So there's an age between 50 and 80. That's when we screen for lung cancer. Also, if someone currently smokes or they quit smoking within the last 15 years. And then we have to do a little math, and this is where it gets fun. But we find out how many packs of cigarettes someone smoked per day times how many years they smoked. And if it reaches 20, then they've now met all the criteria. So that could be 1 pack per day for 20 years. It could be 2 packs per day for 10 years, or any derivative thereof. Sometimes people start and stop and start and stop, so we do a lot of math to figure it out. But I usually err on the side of, yes, it's been 20, so let's get screening. A little bit more about lung cancer. Actually, this is the predominant cancer. So lung cancer deaths outnumber colon cancer, prostate cancer, and breast cancer combined. It's the most common cancer killer of men and women in the United States and the entire world. So it is worth thinking about. There are about 450 deaths every day from lung cancer. And compared to the way we used to screen, which is getting a chest x-ray, although there wasn't really routine screening recommendations for that, so usually it was coincidental. Someone came in with a pneumonia maybe, or they were at a pre-op exam, and so we got a chest x-ray. But compared to the older methods, using this low-dose CT actually decreases the risk of death by 20%, which is excellent. We actually offer the low-dose CT scan here at Hutch Regional, and there are some advantages of this type of CT scan. So it provides excellent detail to detect the smallest abnormalities. It's very safe, low dose, so that means low-dose radiation. It gives off 90% less radiation than a conventional CT scan. And there's no contrast, no IV needed, no contrast. It's very fast, 10 minutes or less, you're in and out. And it's way more accurate than doing a traditional chest x-ray. So it's definitely something that is worth testing for. Again, we have some great lung doctors here at Hutch Regional, and if I find a abnormality on one of these CT scans, I can easily refer a patient to one of the lung doctors who they do some pretty fancy ways of doing lung biopsies that are less invasive. So we went through some misconceptions. These are just kind of my top 3 that I hear on a regular basis that I just want to be sure I have talked about. Again, no one in my family has had cancer, so I don't need screening. I hope we all know that's not true. No matter whether you have a family history or not, it's still important to get screened. I have no symptoms of cancer, so I don't need screening. Again, that is not true. We don't want to wait until you have symptoms to screen. We want to screen when you're feeling great. You're feeling great, you come in for a routine physical, we go through all of the things that are needed for you at this point in time, and we get those done. I would not do treatment, so I don't need screening. And this one is a little bit longer conversation with there are some individuals who are very afraid of things like chemotherapy and radiation. And so they say, I wouldn't do any treatment, so I don't want to get screened for it anyway. And what I usually say is that you don't really know until you know what you would do in a specific situation. And even if you would still choose not to have treatment, it's better to be empowered with knowledge so that you could make that decision. You still might decide that you're not going to do any treatment, but now you've been actually given the opportunity to think about that a little bit more clearly. Also, part of the key for screening early and staying on this schedule is that when you detect cancer at an early stage, you might not need as invasive of treatment. So I have had some women who were found to have breast cancer that just had a lumpectomy and didn't have to have any additional treatment because it had not spread to any lymph nodes. So there is definitely something worth doing, even if somebody might not consider treatment. And that is all I have. Do you have any questions?
How come you didn't talk about PSA?
I didn't, yes. So, and part of that is, I wanted to talk about the core 4, but PSA is something that has become a little controversial, although I'll share my personal opinion about that. PSAs in today's medicine have led to an increase of biopsies, prostate biopsies, which sometimes can cause obviously discomfort, other times harm, and they've led to increased treatment of prostate cancer. That being said, I still, in patients that I have a long-term relationship with, I check the PSA every year just to see if it does spike, so that we can together make a decision if we want to do anything, which I've had men say, no, I don't want to do anything about that, or yes, let's do something. And so I think that it's empowering ourselves with information so that we can have that conversation together to decide what you want to do. So I err on the side of screening men for starting at age 50, and usually it kind of depends on the person, 75, 80, it kind of depends on the person when we stop screening for that. And we do that with a blood test once per year.
Any other questions?
percent of those lung cancer victims are smokers or former smokers?
The majority. The majority. So I can't recall the statistic off the top of my head, but I know it's 75% or greater. So not smoking is the best way to not get lung cancer, but I have had an unfortunate few patients who themselves have never smoked and who didn't have that much secondhand smoke who got lung cancer. And so there's something to do sometimes with certain environmental factors, asbestos and things of that nature that can also lead to lung cancer, but it's probably north of 75%.
So you have to be a former or current smoker to get a CT screen?
So you do, yes. So to get a low dose CT for lung cancer screening, you have to fit all of those criteria. We sometimes have to think about the math a little bit because sometimes it's hard to estimate pack years, but we err on the side of caution. That said, if anyone has a symptom like cough, shortness of breath, weight loss, and we're suspicious, we do kind of head-to-toe screening, which might include a CT scan, although it wouldn't be called the same. It would essentially be the same thing.
Any other questions?
It seems to me the things you're doing are wonderful, but you're almost, seems to me, that you're in competition with our doctors at the clinic.
Mm-hmm.
And like our doctors at the clinic are not allowed into the hospital unless they're a specialist. And I think every idea is wonderful, but those of us that have doctors at the clinic were kind of not being treated the same.
So let me kind of clarify a little bit I'll start at the last part and then go backwards a little bit on that. So there aren't any doctors in Hutchinson that aren't allowed in the hospital. When I have worked in town before here, I used to work at Prairie Star. My patients would say, well, you're not allowed in the hospital. Well, that's not true. They don't stop me at the front door when I try to come in. We all have what are called refer and follow privileges, and that's the same privileges I have. So I have the same privileges in the hospital that all of the primary care providers at the Hutch Clinic have, and at Prairie Star. It depends on what they apply for, but I do know that the primary care providers at the clinic have what are called refer and follow privileges. So I do not have privileges to admit patients to the hospital. I have the refer and follow, which is kind of what I was talking about earlier, that concept that if I find out my patient's in the hospital, I can look at their record, I can consult with the hospitalist to give them information and kind of help follow through on things that might need to happen for the patient. And this is actually a model that we're talking about here locally, not just within my practice, but with all of our practices. And like I said earlier, it's an evolving concept, but I do know that the primary care providers at the clinic share a similar concern with maybe connected from that care. And so we would like to, we collectively, the collective we, primary care providers in Hutchinson, would like to make that better. And so this is something that hopefully I can be a part of, helping to bring those two kind of back together, because I do think the patient benefits from that. To the first part about the being competition. So there have been some studies done based on the size of our community, done by the Kansas Health Institute and then others. Based on the size of our community, our population, the age of our population, a variety of factors. How many primary care providers might we need? And it was shown on both of these different evaluations that it's more than what we have. And so we as a community, regardless of where that primary care provider chooses to practice, need to increase our availability to our patients. I will say from a personal perspective, because I've been seeing patients since March now in this new practice, that throughout my day, a lot of the patients I see are patients that I've had for 10 years, so they're my regular patients. But a lot of them, the rest of them, a large majority of them I will say, are people who actually have been driving to Newton or Great Bend or a variety of places to get care, or who have chosen not to get care at all. So in that sense, it kind of fits right perfectly with that study that we didn't maybe have enough primary care providers in our community. And one primary care provider can only see so many patients. There's a limit for that. And once our panels get over full, it's hard to give each patient the care they need and be available. And so having more help is a good thing, I think.
I have several questions. Are you taking new patients?
Yes.
Does your practice accept Medicare?
Yes.
Standard insurance?
Yes.
What about people with no insurance? Do you
Great
accept
question. So we accept Medicare, Medicaid, most other insurances. I haven't run across one yet that we didn't. And then for people who are uninsured, we have a discount program. So I have, I think it's maybe 15%, I haven't looked this week, but of patients who are uninsured. And so there's a program that they can apply for. There's a department who works with them on finding out what percentage discount they qualify for. And there's a variety of 20 to 100% discounts. So my patients are able to access care even if they do not have insurance.
Should stay back here.
Getting your steps in tonight.
You've been here 10 years?
Not at Hutch Regional. I've been in Hutchinson for 10 years, yes. Coming up 10 years the end of this year.
Where were you before?
Prairie Star.
Oh, you were a Prairie Star. I wondered because it seems like only recently you've been advertised a lot.
That's thanks to my new home at Hutchinson Regional.
Because I thought you just moved back to town, but you've been here 10 years.
No, I've lived here. So when I first moved from Florida back to Kansas, I lived in Hutchinson. Then I decided to get married and live with my husband in Wichita for about a year and a half. And then we bought a house here, I don't know if it's been somewhere between 3 and 5 years ago. Time flies. But the whole, aside from the last year, I've worked at Prairie Star and then Hutch Regional. And then last year, I worked in Wichita for a year.
How old are your children?
So 24 and 20. 24, 24, 20. The twins are obviously the same age.
I just wondered.
Yes.
Okay. I've lived here 34 years. And the clinic was all we had for a long time. I was amazed that Prairie Star grew up and just exploded.
Yes.
And now we have a Hutch Regional also. And I thought, we have so many. Do we have enough people in this town for that?
Well, that study does suggest so, and my day-to-day practice suggests so. I'll just tell you based on my experience working every day, yes. And I will say this, we're in a small town in Kansas, relatively small town in Kansas, and so attracting, talent, physicians and nurses to work in small town Kansas can be difficult. And so us as a community, we have to get creative about how do we get more talent in Kansas. And so for me, thinking through different practice styles, I think we kind of have the best of all the worlds now. We have a great multi-specialty for-profit clinic here in town with a ton of great doctors. We have a hospital-based, a not-for-profit hospital-based practice that is a different experience as a practitioner. And then we have a federally qualified healthcare center. And so we have a little bit of everything here. So in terms of attracting talent, someone can come and gravitate to the place they feel most comfortable at. So that will help us to recruit more people to our area. And also it fits patients differently too. So patients might feel at home in whichever place, and we're all different. We'll go where we feel most comfortable, and that's great as long as we have enough practitioners to take care of our patients, which I think we're getting there.
Good, good.
Yes.
Any other questions?
I didn't quite get what you said about physicians in the hospital.
Mhm.
If I were your patient,
Mm-hmm.
you would be, if I was ill, you'd be able to admit me to the hospital.
No.
How do I get it?
How do you what?
If I'm ill, how do I get it?
How do you get care?
How do I get here? If I'm your patient and I'm ill, how do I get in the hospital if you can't?
Oh, so our hospitalists, so the hospital has what are called hospitalists, and they take, their specialty is taking care of patients in the hospital. And so that group admits the whole town's patients. There are no primary care providers in this town, so people like myself who see people in a clinic. None of us admit our own patients to the hospital. There's the hospitalist group who does that. So it doesn't matter if you're my patient, you're a Hutch Clinic patient, you're a Prairie Star patient, you're still admitted to our hospital underneath our hospitalist team. What we're hoping to do is to kind of have some more synergy between the hospitalist group and the primary care providers. We already have a good amount of synergy, but it could always be improved to improve the experiences. And so our primary care providers have different privileges than the hospitalists. We have different type that allows us to basically have access to the electronic medical record, like look in the computer and see what's going on. But we could also go into the room, meet and greet, say hi to the patient, talk to the hospitalist. We're just not the ones who write the orders in the chart. That's the hospitalist.
So I'm your patient,
Mhm.
I'm ill.
Yes.
You feel like I need
Yes.
hospitalized. You contact a hospital?
Yes, so if you were at home or if you were sitting in my clinic, I would do one of two things based on how ill you were. If you were urgently ill, I would send you to the emergency department. I would call and I would talk to the emergency physician and explain the situation, provide background information to kind of hand you over to that provider to stabilize you. If you are still needing to be hospitalized, but don't need to be in the emergency department, I would call the hospitalist who's working and have the same conversation and work on getting you directly admitted to the hospital without having to go through the emergency department.
So while I'm in the hospital, they are my doctor,
Correct, for any of the primary care in town. But that the part of trying to bring us closer together, the hospitalist and the primary care, is being able to actually physically, or setting up a process where we do a bedside courtesy visit, say hi, or maybe we do a telehealth visit. Maybe there's one of many different ways. Maybe my regular nurse comes and sees you. And like I said earlier, then if you're doing well and everything's straightforward, then maybe you don't have anything you need from me. But if things aren't, or you need some more assistance, or you want me to translate something or convey, then I'd be able to do that.
All right, one more question.
Just suppose I was a patient in the hospital being treated by the hospitalist. The hospitalist reviews my medications that my primary care has been giving to me for the last umpteen dozen years, and the hospitalist decides that I need something different. Is that hospitalist going to consult with my primary care to discuss the reasons why they're going to change it, or do they just do it because they want to?
That's a very complex answer. So technically, the hospitalist does have the full authority to order things for you and to change medications. However, it's the same sort of thing as if you were in the office seeing your regular doctor. What we hope for is there's a conversation that's had with the patient. Hey, I'd like to change your lisinopril to losartan. What do you think about that? Here's the pros and the cons. And now if you're very ill and you're not able to have that kind of a conversation, then sometimes they make those decisions based on their best medical training. Now, as we kind of are closer with our hospitalist team, if there's a medication change that's concerning to a patient, I'm sure there can be cases in which that's concerning. The hospitalist has the ability to reach out and talk to the primary care. The patient has the ability to call their primary care doctor or have their loved one call their primary care doctor to say, hey, I'm a little concerned. Hospitalist so-and-so would like to change my whatever to something else. Can you intervene on my behalf? And that's fine. We can have those types of doctor-to-doctor conversations to try to figure that out.